acute aortic syndrome, is a non-contrast phase really necessary? I have nothing to disclose. So a little bit of background. As you know, acute aortic syndrome describes three clinically sometimes indistinguishable abnormalities: aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. And we always do a contrast phase, of course, but in addition to that, we've traditionally performed a non-contrast examination to exclude the presence of intramural hematoma. And although this has been advocated as part of the protocol, recently some people have questioned the incremental value of the non-contrast phase, although the evidence in the literature so far has been limited. So we hypothesized that we could detect intramural hematomas alone with contrast-enhanced images only. So first of all, a little bit of a small definition. There's multiple definitions of intramural hematomas in the literature. It can be a little confusing. We defined it by perhaps the narrowest of definitions, which was acute hemorrhage within the aortic wall without a visible intimal defect. And that's distinct from a thrombosed aortic dissection. As you can see here, that this displays the classic appearance of an intramural hematoma with wall asymmetry and hyperdensity. So we performed a matched case control study using consecutive patients. We initially performed a retrospective search for all CTHS that were performed for acute aortic syndrome at Harborview Medical Center from 2005 to 2010. We came up with a total of 839 exams, and we excluded about half of them due to the exclusion criteria on the left, which were often wrong indication or duplicate records, and came up with a total of 423 new acute aortic syndrome workups. And from this, we detected 11 actual intramural hematomas, which was a prevalence of 2.6%. And that's distinct from the thrombosed dissections, as I said. And our gold standard was consensus on image review between radiologists. So we took those 11 intramural hematoma cases and matched them for blinded image review. So we randomly selected our controls from a workup cohort using normal controls, that is without aortic pathology, and also abnormal controls. So they had either aortic dissection or penetrating atherosclerotic ulcer or both, but no intramural hematoma. And all controls were age and gender matched. And we matched 2 normal controls per IMH case, and then matched all of the abnormal controls as well. It came out to be a total of 45 cases. So we 3 independent blinded reviewers looked at the contrast-enhanced images only, and for detection of intramural hematoma, aortic dissection, and penetrating atherosclerotic ulcer. And for intramural hematoma specifically, they were asked to give a 5-point scale of their confidence. So 1 would be definitely no, and then 5 would be definitely yes, and then there's some probable or maybe between. And then we also asked them to indicate whether they would order a follow-up non-contrast CT based on their confidence in the diagnosis. So here are our results. So we had only 2 false negative intramural hematoma reads. That's 2 of 3. That's 11 reads for the 3 reviewers. And those both received a confidence rating of 2 or 3. So one received a maybe and the other one received a probably no. There were 21 follow-up CTs that were recommended, so about a sixth of the cases. About half of the intramural hematoma reads were non-contrast CT was requested in those cases, so a high proportion, and a few of the control reads. And overall, we also had 6 false positive intramural hematoma reads. And our inter-reader reproducibility was good at about 0.8. So here's our sensitivity and specificity. The important line is the one underneath. The up top are the raters individually, and the bottom line is overall. And on the left-hand side, you can see sensitivity was 94% with the confidence intervals next door. And then on the bottom right-hand, our specificity was overall 94%, including all controls. It was our specificity was better compared with normal controls, as you'd expect. So here are 2 false negative cases. You can see here the non-contrast images. These, of course, weren't reviewed. And these were the images that were, the contrast was above and the non-contrast are below, of course. And as you can see, they're both in the aortic arch, interestingly, and I think they're both subtle cases. So for those two negative cases, as I said, the confidence rating for that diagnosis wasn't definite, and in both cases they actually ordered non-contrast CTs for those cases. So we calculated that if a delayed CT was ordered only when our raters only had a confidence level other than 1 or 5, so a confidence level that wasn't definite, we would only be ordering about 14% of delayed scans and non-contrast equivalent for our cohort versus 100% as the protocol would demand. And in that case, no intramural hematoma cases would be missed using this conservative approach. So in conclusion, a non-contrast examination is likely unnecessary for the diagnosis of acute intramural hematoma. We should order a delayed post-contrast CT for a suspicion of intramural hematoma for cases where we're not sure about the diagnosis. And this can potentially be dose-saving change and also savings in time by eliminating the non-contrast phase. And we're in process actually at Harborview and changing our protocol. We're actually changing to a routine non-contrast phase for patients who are over 50 years old only, and under 50 years old we'll only be doing them as needed. Thank you.
Thank you very much. We have a couple of minutes for questions. Does anybody have any question? And if so, I'm going to ask you to step up to the microphone. Yes, sir.
Do you measure the threshold Hounsfield unit for contrast CT exams for intramural hemorrhage?
We didn't measure the Hounsfield units of the, let's see, so we, as the study, putting together the study, we didn't measure the Hounsfield units of the aorta. Whether the reviewer may have measured the Hounsfield units of the aorta, because each of, I didn't mention this in here, but all of the cases were de-identified and put on PACS for PACS image review. So they had the full range of the PACS tools. So.
Maria?
In the case where you would recommend a delayed phase, where you on the contrast it's somewhat suspicious, so you want a post-contrast delayed, how delayed is that scan typically? What's the recommendation?
You know, I don't have a good answer for that. I can come up with one, but there are better people than me, I think, to answer that question, so sorry.
Chris, I have one question for you. We actually, at our place, do a non-con, and we find it very helpful for distinguishing a type A versus a type B intramural hematoma. Okay. Did you look at the distribution at all, and the reader's confidence in saying it was a surgical versus a medical lesion?
You know, that's a nice point. We didn't actually look at that, but that's an interesting point that you make, and it would be worth taking a look and seeing if there's a difference.
Do we have any more questions? All right. Thank you very much.
Thank you.
We're going to go to our next speaker, Dr. Portnoy, who's going to continue with the theme and provide another institution's experience with looking at the intramural hematoma and the value of the non-contrast phase.
So I actually had the privilege of seeing the University of Washington, Dr. Potter's abstract when they were submitted, and then I had the privilege of hearing it today, and it was a job well done. I'm glad that we had the same clinical question with a similar clinical outcome. Our study design was somewhat different, and so I want to focus on some of the differences between our study designs and maybe a slightly different focus in terms of the conclusions. So the acute aortic syndrome is, of course, an important disease to discuss the spectrum in general, of course, because of its high mortality rate and the rapid reversibility if definitive treatment is administered in a timely fashion. Of course, clinical presentation is very challenging at times. There are a number of mimickers of the disease, and so it can be very frustrating to discern one from another. And so, of course, this has become a diagnosis largely of radiologic imaging. And so, to discuss the three different, along the spectrum of the three different diseases that were just discussed, dissection was the first of the three, of course, with the most worrisome complication profile. And what we required when we were looking through, when we wanted to define parameters for the different types of diseases, we wanted to see a true endomomedial flap the way it's been described in the literature multiple times, in contradistinction to the others. Of course, there was at least some knowledge of an indirect communication between the true and the false lumen, at least by virtue of contrast distribution, if not a true obvious source of communication. Penetrating atherosclerotic ulcers, of course, are a slightly different disease spectrum, slightly different disease along the spectrum. Requires oral contrast imaging the same way aortic dissection does, and this, of course, can be a harbinger for other diseases to follow, or in and of itself can have its own clinical sequelae. And, of course, intramural hematoma, which is always traditionally there's been that anecdotal evidence, well, you can't see it on post-contrast imaging, let's have a pre-contrast image. But the data has always been very scant for it, as we've just heard, and so people have been doing it really based on anecdotal evidence more so than they have been on any scientific study. And so that's what we sought to discover. Now, whether or not these three diseases are one disease on a spectrum or actually can act independently of one another was a source of debate. This question's been asked since the early 80s, but actually is something that really we've recognized is probably true, and unrelated. The majority of the cases probably do exist on a spectrum, but there are a minority of cases, of course, which will act independently of one another for a host of different reasons we discussed, surgical, medical, and others. And so what we looked at was there was that wonderful IRAD, the International Registry of Aortic Dissection, which had it was a multinational, multi-hospital consortium that came together to compile as many of these cases as they could. And they had a host of wonderful epidemiologic and prognostic values that they were able to disseminate as a result of their study. And so what was most striking is this 5.7%. So in the 5% range, so the University of Washington group had somewhere in the 2s, this group was somewhere in the 5s. It's a low prevalence, very low prevalence among those who have true positive. When you consider all comers, of course, that number is even lower. Also to consider is the mortality rate, at least in the acute setting, IRAD published as 21%. We'll come back to that number. It is important. And so the question asked is the same way we've just heard. How many of these are we missing? It's so low prevalence, and if we are missing any of them, is that number statistically valid to warrant double the radiation dose, double the time, scanner time, radiologist time, etc. And so we had a retrospective non-inferiority blinded study. We hypothesized a non-inferiority study, non-inferiority that post-contrast imaging alone would not be inferior to pre- and post-contrast imaging. And so we had same window, 5 years, over 1 million patients. We looked for the words intramural hematoma, 1,000 of which were returned. Most of all were no evidence of. 23 cases who had, this is important, it wasn't just true intramural hematomas, but they also had to have pre- and post-contrast imaging in the same set of scans. So a little bit different design. We necessitated that there be pre- and post-contrast imaging on board. And then we took 23 case controls, age and gender matched. And so we had 46 total patients, and we split them up. So we took the 46 patients, 23 cases and controls, and gave 5 thoracic fellowship-trained radiologists the opportunity to look at these images in just post-contrast isolation. Now, of course, there were only intramural hematomas and or controls, no dissections, a little bit different as well. And we asked them, are any of these diseases present? And then we gave them a few-month break, and then we asked them the same question with the same 46 patients, but this time we introduced the pre-contrast imaging and asked them, do you see it? And really in isolation from one another, and we wanted to compare these two sets of data. Did pre- and post-contrast really yield any benefit over post alone? Slightly different study design, but with the same question at hand. And so the answer was no, they didn't. And so these numbers are a little bit skewed, and perhaps we can discuss them afterwards, but this 73% versus 77% revealed a p-value difference that was statistically insignificant. There was a little bit of confounding here, perhaps because of the fact that some of the readers may have called something not an intramural hematoma. They might have called it a dissection, but that would throw the numbers off as being somewhat less accurate. But their overall, the statistical difference between the two of them was insignificant. A very high p-value, well over 0.05. And the number that I think was most relevant, that really is the number to consider, is this 9% or 8%. So the worst case scenario, we think there was no difference right down the middle here, but if there were a difference, it would be at worst 9%, 8%. And when you consider that from an epidemiologic standpoint, the fact that there are approximately 11,000 cases of aortic syndrome a year, the fact that only 5% of those at most, maybe even 2% of them, are going to be intramural hematoma, you're talking about 500 cases annually. When you talk about a miss rate of 9% at most, we think there won't be any. You're talking about 0.4% of cases, 4 out of 1,000 cases that are missed. When you consider that only among true positive disease-present patients, you're actually talking about, when you incorporate all of the negative patients that we scan, which are the majority, well under 1 in 1,000. Important to note. And then when you consider the fact that 21% of these patients will die of it, only 1/5. So you're scanning 5,000 patients for one mortality benefit. Now that's important because you have to consider the alternative, the cost, the risk associated with this, right? And when you have, you're scanning 5,000 patients to confer one life-saving potential intervention. You remember, we're scanning 5,000 patients. The FDA tells us, this is actually pretty shocking, but I'd never seen this statistic before, but with a 10 millisievert dose of radiation, you're conferring 1 in 2,000 cancer-related deaths from those scans on a stochastic risk basis. So you're scanning 5,000 patients to save a life, 5,000 patients to find 5 IMHs, but those 5,000 scans are going to confer 2.5 cancer-related deaths. So it's something to consider. So, in conclusion, if you are actually conferring a benefit, which is questionable, I guess from both of our opinions, that risk, that benefit is very small. And when you consider the risks, the costs, not only the radiation dose, but the scanner time, radiologist time, limited resources, it becomes highly suspect that a pre-contrast set of imaging is necessary. And so we feel that there probably is no need for it. Of course, because of the disease prevalence, it's a small subset. We only found 23 patients. The other group, also a smaller group. Larger scale confirmatory study would be warranted, but difficult given the fact that the disease is hard to identify. Thank you very much.
Thank you very much. We have a couple of minutes for questions. Does anybody have any question? I actually have a couple. The same question that goes back that we had asked Chris is that did you look at the distribution of the intramural hematoma? Because sometimes the type A is a lot easier to see on the non-con. And then I was also struck by the fact that you said that you had 5 thoracic radiologists who are fellowship trained. And in our experience, the non-con is very helpful for the junior person and the non-chest radiologist reading. And so did you look at that as well? Because I think many of us don't have chest radiologists taking call at night.
It's an interesting question. So to answer both of those questions, we discussed a couple of those things afterwards, but didn't look at them at the time. The question of intervention, ascending versus descending, your point is well taken that ascending may be more difficult to perceive, but we felt that from a clinical standpoint, almost all cases, if it's IMH, if it's IMH or dissection, if you're able to discern that there is pathology in the ascending aorta, the clinical intervention doesn't change. Ascending geography versus descending geography doesn't have an impact per se on the therapeutic intervention, as long as you can detect the fact that there was some pathology there. Whether or not it's more perceptible on an ascending aorta, we didn't consider, and it's something to think about.
At least at our place, if there's a type A intramural hematoma, they'll go to the operating room, and if it's type B, they'll treat them medically.
Oh, absolutely.
So that's where we found it to be
absolutely.
Very helpful.
Absolutely.
And then just a follow-up question was that did you, for your pre- and post-con, do you change the dose at all? Many centers have described using a low-dose non-contrast to bring it down to almost screening CT level so that they could avoid some of the problems that you've alluded to.
Absolutely. So that's a fair question. The frustrating part about intramural hematomas is that given the fact that they are so rare, being selective of the type of scan retrospectively that we were going to qualify would have eliminated the vast majority of them.
So in your dissection protocol, they're the same dose for the pre and post?
Oh, in those cases, yes. So yes. we didn't necessarily need a triple rule-out study. We wanted any CT scan that was pre and post contrast scanning. But yes, so in our case, yes, we do have a standardized dose. I don't know the protocol, to be honest with you. I think Dr. Shao may know it, but I don't actually know it off the top of my head.
Awesome. Yeah. Are there any other questions? Well, thank you very much.
Thank you very much.
We're going to switch gears now and move to the discussion of the pulmonary embolism, and I'm going to invite Dr. Shahir from the Medical College of Wisconsin to share their experiences with modifying the pulmonary embolism protocol.
Hi everyone, I am Kaushik Shahir from Medical College of Wisconsin. As Dr. Bala mentioned, I'm going to switch gears here. My research topic is reduced Z-axis CT pulmonary angiography in pregnant women for pulmonary embolism. Do we really miss any important diagnosis, and how much is the resultant dose reduction? So if we look at there are different dose reduction methods. You can just go on, it's a different talk, but of this is one important technique which is called as the reduced Z-axis. The technique is pretty straightforward. Instead of scanning the entire chest, we scan from the aortic arch to the base of the heart or the top of the diaphragm. Now, mind you, this is not a new technique. There is always a concern whether we are going to miss any important diagnosis. People have looked at this method in different ways. Callan's group and Atali's group were the people who looked at it. They looked at very specific findings. Callan looked at the distribution of PE, and they mainly concentrated on general population, and they found out that we don't really miss any PE diagnosis. Atali's group looked at PE as well as non-PE abnormalities, and also they looked at in general population, in which they also projected the same kind of results. So we created one more project which was published recently, in which we not only looked at these findings, but we concentrated on a very specific age group, which is 18 to 40 years age group, where there is a very little concern of missing a big lung cancer or a big abnormality. And we also found that we did not miss a PE. In addition to that, we found that the dose reduction was a whopping 69%. So the purpose of our examination was whether we can really try and apply this same method in pregnant population. Do we really miss any big diagnosis, and what is the dose reduction resulting? So pregnant population is extremely sensitive. Everybody is talking about reducing dose not only to the mother but also to the fetus based on the ALARA concept. So in this retrospective IRB approved study, we had two parts to this study. In part one, we looked at the data for 9 years, in which all the pregnant women who underwent CTP exams were identified. Those who had inconclusive studies were excluded. The scan parameters were pretty standard. There was some variation, but most of them had smart MA technology. These scans were then modified by our 3D tech in the 3D room, in which she removed the images above the aortic arch and below the base of the heart. The new series were created, loaded onto the PACS on a workstation. Now these were then assessed individually by 2 independent readers who scored them for PE and non-PE abnormalities. Now their results were then compared with the original read by the third radiologist. Part 2 of this evaluation was a part of quality control project, in which the DLP distribution on the 3 zones was assessed on the CT console itself. While planning an examination, if you plot 3 different zones of acquisition, the scanner console itself gives you a DLP value for the distribution as shown in this photograph. So we did this for 36 patients. These patients were not pregnant. So coming to the results, we had 95 scans performed in 9 years. 11 patients had inconclusive studies. So we had 84 patients in total. Two were positive for PE, 32 were completely normal, and 52 had non-PE abnormalities. This is just an just a tabular distribution of how we divided the findings as potentially important findings and incidental findings. Looking at the reader performance, we did not miss a PE. As expected, there was extremely good inter-observer agreement. 2 out of 2 PE was identified. Pertinent findings, 60 out of 60 pertinent findings were identified. 4 out of 16 incidental findings were out of range, were missed. Now these were 3 benign nodules, 1 small incidental nodule. Now the third reader had the opportunity of looking into the future reports or records of the patients, making sure that none of these findings actually influence the management or outcome of the patient. Dose evaluation, zone 1, you can see the DLP of 187, zone 2 DLP of 142, and zone 3 of 161. Average dose reduction, again here, turned out to be 69 with a range of 45 to 90%. The scan length reduction was 41%, which matched with our studied group. So you can look up here in the scout that zone 2 is really big compared to zone 1 and zone 3. The concept behind reduced DLP is the smart MA. The smart MA turns on a higher dose when you are scanning the higher attenuation region like the shoulder or the upper abdomen. So if you get rid of these regions, you end up with a very significant dose reduction. So limitations of our exam was we calculated the dose on a different population, on a small population. It was a retrospective method. Only 2 patients had PE, so one can question the power of the study. But mind you, this is data for 9 years of pregnant women who underwent CTP exams. So summarizing the results, we did not miss a PE diagnosis. There was no pertinent finding which was missed. There were few incidental findings which were out of range, and dose reduction is quite significant. In fact, we have implemented this same protocol for all the pregnant PE studies which we do at our hospital. If we combine this method with the newer iterative reconstructions like MBIR, we can potentially have a significant dose reduction. Thank you.
Do we have any questions from the audience? I think somebody's coming up to the podium.
A bit short, sorry. Hi, thanks for that. I was just wondering, you were talking about doing CTPAs in these pregnant women. What about just a perfusion scan in the pregnant population, particularly if they've got a normal chest X-ray? Did you look at that cohort of patients, or do all your patients get a CTPA?
Well, the protocol for going for a perfusion scan has come up very recently. It was mainly based on the guidelines recommended by Society of Thoracic Radiology, American Thoracic Society, and Gynecops. Now we have that protocol. If our chest X-ray is normal, only then the patient goes for a VQ scans. However, our ED still doesn't understand the concept, so we have to go in for what they ask for. So.
Okay, thanks.
I just wanted to follow up on, you said that there was a 69% reduction in dose. What approximately is the effective dose of that limited range if you were to calculate it? Did you get any sense of how it would compare to a VQ scan of about 1.2 millisievert effective dose?
It would be around, it would be like 2 millisieverts.
So about double, but not that much more. Interesting. It's very interesting. I think one thing that a lot of centers have reported is that when they include the thoracic outlet in their PE protocol, it's amazing how much dose is brought on by the dose modulation software. We have time for one more question. Does anybody in the audience have any questions? Yes, I'm going to ask you to come over and get to the microphone, if you could, just so we could hear your question. And forgive me, if I'm ignoring some of you, it's not intentional, it's just the light is obscuring the back of the room. Yes, sir.
I just wondered whether you know how long the Z-axis is from aorta to top of diaphragm.
It's approximately 15 centimeters.
So a 16 centimeter detector will cover most of your patients.
Mm-hmm.
Very good. Any additional questions? All right, thank you very much. We're going to invite the next speaker up, Dr. Cho, who's going to now speak to us on further attempts at trying to lower thoracic emergency doses. Dr. Cho.
Thank you, Chairperson. I'm Jae-young Cho from Aju University Hospital, South Korea. I'd like to present about feasibility study of low-dose chest CT for initial evaluation of blunt chest trauma patients. As we know, computed tomography is most important diagnostic modality in emergency department due to its effectiveness in traumatic and non-traumatic conditions. Especially chest MDCT is accepted as effective and fast imaging tool in severely injured traumatic patients. And recently, this modality is used increasingly in the less severe injured trauma population. We searched one recent study suggests that routine use of MDCT in traumatic patients rather than selective use of MDCT due to its substantial added diagnostic value of routine CT scan. But there is no consensus of CT indication in traumatic patients. One of the main causes is excessive and harmful radiation. A traumatic patient often requires multiple imaging tests using radiation. So there has been many trials for radiation dose reduction. One of the emerging technique is low-dose CT scan. Many reports present that low-dose CT scan could achieve substantial dose reduction without difference in subjective image quality. So we hypothesized that if there is no difference in diagnostic effectiveness between low-dose and standard dose CT scan, we can use CT scan more in traumatic patients without concerning of excessive radiation exposure. The purpose of this study is to evaluate the feasibility of low-dose CT for initial evaluation of blunt chest trauma. From August 2012 to December 2012, we searched the patients who had blunt chest trauma in Aju University Hospital. All patients underwent pre-contrast low-dose CT scan and standard dose CT using intravenous contrast agent. On the low-dose CT scan, tube current was 40 milliampere second and tube tube voltage was 100 or 120 kilovolts peak according to patient BMI. On the standard CT scan, tube current was 180 milliampere seconds and tube current was 120, the fixed value. And reconstruction in each scanning data included transverse, coronal, and sagittal plane images, which were 3 millimeter in slide thickness without gap, and the following rendered image was also taken. We used the standard color reconstruction. Each dataset were randomly arranged for evaluation, and 4 readers, including 2 radiologists and 2 residents, independently evaluated each CT dataset. And they were aware of blunt chest trauma history and focused to detect traumatic injuries. To establishing reference standards, 1 millimeter slide thickness reconstruction was obtained, and 2 radiologists agreed on a consensus. 4 observers checked each findings with the 4 confidential scale. First, definitely positive. Second, probably positive. Third, probably negative. And last, definitely negative. We evaluated pulmonary, tracheobronchial injury, skeletal trauma, mediastinum, aorta, diaphragm, chest wall, and upper abdominal solid organ injury. Let me present an example of cases from this study. 24-year-old male patient who had blunt chest trauma due to pedestrian traffic accident. We evaluated 3 planes of CT scan and following rendered image. We can find traumatic injury of pulmonary contusion, sternal fracture, substernal hemorrhage, and easily on both scans. So our comparison analysis was done for evaluating diagnostic performance between low dose and standard dose CT, and intra-class correlation coefficient analysis was used to confirm inter-observer consistency. As a result, this table showed the demographic finding of patients. 71 patients were enrolled, and most common cause of blunt chest trauma was car accident. This table shows the type of injuries, and the numbers mean per patient count. The most common injury was rib fracture, which were followed by pulmonary contusion and hemothorax. Average radiation dose was 2.67 milligram low dose CT scan and 30.4 milligram standard dose CT scan. Low dose CT scan showed about 78% radiation dose reduction. Our comparison analysis will reveal that there is no significant difference of diagnostic performance in pulmonary injury and all skeletal trauma, hemothorax, and chest wall injury. This result corresponds with our expectation that low-dose CT scan would show good diagnostic performance in traumatic injury except vascular injury and abdominal solid organ injuries. Intra-class coefficient analysis showed that moderate to substantial agreement in traumatic injury, except also in aortic injury and abdominal solid organ injuries. There are several limitations in this study. First one is small number of cases. Secondly, we did not use iterative reconstruction technique. As we know, this technique could reduce radiation dose and artifact. And third is about contrast enhancement. This case is an example of our study. The patient who have aortic dissection. And it is difficult to find vascular injury on pre-contrast image alone. So further study of low-dose CT scan with IV contrast use is mandatory. In conclusion, low-dose CT scan have great potential benefit to maintain diagnostic imaging quality and to provide significant radiation dose reduction. Okay, thank you for your attention.
Do we have any questions from the audience? I just had one question to ask you, and that was, how did the low dose do with patients with very large BMIs? I know many of us are in centers where we have BMIs that are traditionally above 30, or I just saw a patient with a BMI of 45.
Right. In fact, in Korea, there are a small number of very large BMI patients. So we enrolled 71 patients, and they are all under BMI 40. So we do not have any supporting data about that. So it is mandatory to make a further study.
Does anybody have any other questions? All right. Thank you very much. We're going to continue with the low-dose theme, and I'm going to invite Dr. Yi, who's going to come speak to us on low-dose, looking at the fishbone as a foreign body in the esophagus. I know a problem that some of us have dealt with, and it can be really perplexing when you have a patient with a suspected foreign body.
Thank you. I'm Furami from Aju University School of Medicine, Republic of Korea. Sharp fishbone is fragile foreign body as very practical situation because it could invoke foreign body-induced rectal complication, including mediastinitis and perforation of aorta. MDCT is very useful imaging tool for evaluating if fragile foreign body. In the emergent circumstance, after an initial negative clinical inspection of the oral and the hypopharynx, the MDCT would be first choice modality. Low-dose chest CT or ultra-low-dose chest CT is recently used for evaluation of lung parenchymal disease because of its high intrinsic contrast and low attenuation. However, these have some limitation for evaluation of mediastinum due to inherent narrow range of attenuation densities and noise from photon starvation. Recently, we accumulated experience with CT examination using IDOJ-4. Empirically, we deduced that high density is fragile foreign body would be well detected on sub-millisievert CT examination using IDOJ-4 IR. Therefore, this present study was aimed to evaluate the usefulness of very low-dose chest CT as an initial imaging study for sharp fishbone is fragile foreign body. From January 2012 to January 2013, there were 38 patients who visited the emergency room with an obvious history and the symptom of sharp fishbone is fragile foreign body were included. All the patients underwent primarily careful oral examination and indirect laryngoscopy and were revealed to have negative findings. All the CT images were acquired with 20 milliampere and 100 or 120 kilovolts on 64 detector row CT. CT image reconstruction was subsequently achieved with X-ray and coronal planes using both FPBP and IDOJ-4 IR techniques. Diagnosis of fishbone EFB was confirmed by flexible EGD and surgery. Vendor providing CT dose index volume and dose length product were recorded as radiation dose descriptor. All the images were evaluated by 3 observers who are experienced thrashing radiologist, third grade training of radiology, and an emergency physician. Positive findings were defined as direct identification of high-density foreign body or identification of secondary findings including soft tissue edema, hematoma, and pneumomediastinum. Subjective image noises were recorded using 4-graded scale as thoracic and neck, pulmonary trunk, and lung base level. The standard deviation of attenuation and the ROI were measured and used as the objective image noise. Circular ROI were placed in left brachiocephalic vein, pulmonary trunk, and descending aorta of lung base. Statistical analysis was performed as follows. Here are the results of our study. Mean radiation dose was 0.46 millisievert, and total 33 patients were identified as having fishbone EFB. 5 patients were labeled as not having EFB. The objective image noises were significantly lower in the image with using iDose 4 IR. The subjective image noises were also significantly better in images using iDose IR. The qualitative noise score was about 3 in iDose 4 IR, which is considered as acceptable image noise, and about 2 in FPP images, which is considered as suboptimal image noises. Diagnostic performance of low-dose chest CT for evaluation esophageal foreign body was good to excellent in all readers and its techniques. There was no significant difference of diagnostic performance between observers. Let's see an example. The sharp high-density fishbone esophageal foreign body is well identified in both FPP and iDose 4 IR images in thoracic esophagus. This foreign body was removed by flexible EZD without complication. This is an example of a false positive made by emergency physician. As you can see, the image of FPP is motor and grainy image texture. The emergency physician diagnosed a cervical esophageal foreign body only on FPP images. Inter-observer consistency was very excellent in its reconstruction technique, and among 5 true negative cases, the emergency physician diagnosed 2 false positive regions reviewing CT data of FPP. In conclusion, very low-dose chest CT using iDose 4 provides satisfactory diagnostic imaging quality for identifying fishbone EFB. Therefore, ultra-low-dose CT would be adequate as first imaging modality for sharp fishbone EFB. And iDose 4 IR would be useful to reduce mediastinal imaging noise mimicking esophageal foreign body. Thank you.
Are there any questions from the audience? Just one question. Did you think that if there was a fishbone in the stomach, you would be able to see it with a low-dose technique?
Actually, it's very difficult to identify the fishbone in the stomach because there are so many other hyperdense material in the stomach after the meal.
Thank you very much. I'm now going to turn over the podium to Dr. Patlas, who's going to continue with the last 4 presenters for this session.
So, and we continue with topic of pulmonary embolism. I'm glad to invite Dr. Moyer from Edinburgh, United Kingdom, to talk about increased referral rate for investigation and increased incidence of symptomatic pulmonary embolism.
Good morning, I'm Kenneth Muir from the Royal Infirmary of Edinburgh. I'd like to present some work we've been doing looking at the investigation and diagnosis of pulmonary embolism at our institution over the last 10 years. Here are our disclosures. So until relatively recently, perfusion scans or Q scans were the first line investigation for pulmonary embolism. They have the advantage of lower radiation exposure than CT, and we still use them quite frequently for younger patients or pregnant patients. However, the results are often inconclusive or indeterminate. CT has a wider diagnostic scope and allows diagnosis of conditions other than pulmonary embolism, and really has become the primary method for the investigation of PE. And there's been a well-documented explosion in the use of CTPA. Along with that, we've also seen an increase in the incidence of diagnosed pulmonary embolism. A recent study from the United States showed that the age-adjusted incidence increased by 80% in the 8 years following the introduction of multi-detector CTPA. That was in 1998 to 2006, having been stable for the 5 years before that. And there's now a growing hypothesis that newer technology, higher resolution CT scanners allow the detection of smaller emboli that previously wouldn't have been diagnosed. This is a paper that was published in the British Medical Journal this summer, researchers from Boston, which was very interesting and posed a few very good questions, amongst which was whether we're diagnosing smaller emboli that perhaps don't need to be treated. This is a more recent study, again originating from America, from New York, highlighting the fact that we seem to be diagnosing more smaller emboli. So the purpose of our study was really to look at the investigation and diagnosis of pulmonary embolism at our institution over the last 10 years. We conducted a retrospective review of records at the Royal Infirmary, including both CTPA and Q scans, and that's for suspected acute pulmonary embolism. So this is symptomatic patients, not incidental findings. We included the years from 2002 to 2012, so a 10-year period. Along with that, we also took a final year cohort of positive scans, of which there were about 400, and we categorised them using the modified Miller score. Some data from this study has been published previously, and we're able to compare to that earlier data, which was useful. So here are the results. As perhaps we would expect, we saw a quite substantial increase in the total investigations for suspected acute pulmonary embolism. So in the 10-year period from 2002 to 2012, there was a 111% increase in total investigations. And as you can see, that's mainly due to a substantial incremental increase in the number of CTPAs that we're performing. So that went from about 700 per annum to more than 2,000. And along with that, we saw a relatively modest decline in the use of Q scans from about 290 per year to 90 per year. Surprisingly, our positive scan rate remained quite high, so we have a 20% positive scan rate, which means that we're diagnosing a lot more pulmonary emboli. We're now diagnosing more than 400, whereas 10 years ago it was nearly 150, and that's for virtually the same patient population. We also observed increased diagnosis in an older population. So the mean age went up from 62 to 65 years. And particularly when we looked at the demographics, we saw that the diagnosis of pulmonary embolism in the older age groups in the 80s and 90s has really seen a quite dramatic increase. So we're diagnosing more pulmonary emboli, but is it due to these, is it because we're diagnosing smaller emboli? So to look at that, we looked at the severity of pulmonary embolism using the modified Miller score. And this is really a scoring system that was devised for conventional angiography and then modified for use with CTPA. A filling defect in a segmental pulmonary artery scores 1 point. A defect in a more proximal vessel scores the number of distal branches. So the maximum score you can have is 16, and the minimum for a positive scan is 1. And this was quite surprising. When we looked at the data from 10 years ago and our more recent data, and now obviously this table has been corrected for numbers because we're now diagnosing a lot more emboli. When we looked at the proportion of the Miller scores throughout the positive scans, we see that the disease severity pattern hasn't changed substantially over the last 10 years. As you can see, the Miller score 16, the largest emboli, we're still diagnosing more frequently than any of the other pulmonary emboli. There's perhaps been proportionally a slight reduction in Miller score 16s. And at the other end, we see that there's about a 5% increase in the Miller score 1s, the smallest emboli. But the overall pattern hasn't changed too much. There's perhaps a slight tilt in that direction. So in conclusion, as we might expect, we saw a major increase in investigation of symptomatic acute PE. And really that was mainly due to a substantial increase in CTPA, and that follows trends we're seeing elsewhere. Our positive scan rate remained high, resulting in a significant increase in the incidence of acute pulmonary embolism diagnosed. We observed an older population with PE, and that's interesting. That may be a reflection of, number one, of an ever-aging population, or also of a change in clinical practice where we perhaps have a better access to CTPA and have a lower threshold for scanning older patients. Surprisingly, our hypothesis doesn't really support the diagnosis that the increased incidence of pulmonary embolism is purely due to the diagnosis of smaller emboli, although it has to be said that that may be explained by the fact that we're diagnosing emboli in a different population. The demographics have changed slightly, and it may be that older patients are more prone to more severe emboli, and that's something we're going to look at next. Thank you very much.
you very much for presentation. Now it's open for questions. Questions from the audience?
Thanks very much. Just wondering, with your retrospective analysis, did you happen to have any information in the percentage of patients that were sent to intensive care unit or to surgical thrombolectomy in terms of the high-end severe thrombi? Did that stay the same over the time? So we're diagnosing more PEs, but the severe PEs are still the same proportion.
Yeah, thanks. That's an interesting question. We didn't actually look at that. It was a retrospective study. That's not something that we included in our analysis. But an interesting finding was that the Miller score 16, so that the very large emboli are still the most common emboli that we're diagnosing.
More questions? I have a question. Let me ask you. You mentioned that you see less VQ scans than before.
Yes.
Is VQ scan available in your institution after hours, 24 hours, or you can do on?
No.
It's the same policy in our place, so I think part of the explanation is that just you cannot get VQ scan at night, so during the weekends.
Yes.
Dr. Bala?
Yeah, no, the same for us is it's a little bit more tricky, but we do offer it at night. But we've noticed the drop too because it's a lot easier to order the CT and get it done.
Yep, there's quite easy access to CT.
And is there any policy in your place to order CT for pulmonary embolism? What's the criteria?
For younger patients, we tend to try and, if we can, do a Q scan. So if they have a normal chest X-ray and they're a young patient or a pregnant patient, that would tend to be the first line. But we're seeing that we're doing a lot more CTPAs than ever before.
Yeah, no, it's also my observation from our institution. So, okay, thank you.
Thank you very much.
The next presentation is from Dr. Scott Atkins from Loma Linda, California. Cost and risk analysis of CT pulmonary angiography to rule out pulmonary embolism in low and very low risk emergency room patients.
Hello, I'm Scott Atkins from Loma Linda. Again, I'll be talking about the cost of CT pulmonary angiography to rule out pulmonary embolism in low-risk emergency department patients. So for some background, a recent study showed that 1/3 of CT pulmonary angiograms from the emergency department to rule out pulmonary embolism in the United States are potentially avoidable. This is because they showed that 22% of these patients are low risk clinically and did not have a D-dimer performed, and that 11% are actually very low risk with a negative D-dimer. As we know, we use that for its strong negative predictive value for PE. So this means that there's a potential of 600,000 avoidable studies each year in the United States. The goal of our study was to determine the additional cost and if patients are actually harmed by this potentially avoidable imaging. For our methods, a literature search was performed looking at the use of CTPA and on PE outcomes. We looked at prospective and retrospective studies from 2000 to the present. A decision model was constructed using Triage Pro software for evaluating these low-risk ED patients for pulmonary embolism. And the model was constructed from the payer point of view, but looking at patient quality of life as the outcome. We proposed 3 alternate strategies to the current U.S. practice. These included D-dimer followed by CTPA only if the D-dimer is positive, an ED observation unit, which is based on the model of chest pain observation units. We understand that these are not available at all institutions. And finally, performing CTPA initially on all of these patients. The costs and the patient utilities for each outcome were plotted to determine a dominant strategy. And a strategy is considered dominant if it has lower costs and better outcomes based on quality adjusted life years, with a willingness to pay of $75,000 per quality. Sensitivity analyses were performed over a wide range of clinically relevant values, and a Monte Carlo simulation was also performed. So here's the decision model, which actually is not projecting at all, which is great. But we'll go into the model here. We have the 3 different alternate strategies, which include D-dimer followed by CTPA. And this patients get if they have a positive D-dimer, then they go ahead to the CTPA group and get their diagnosis based on that and receive treatment and have potential outcomes and costs along the way that we're able to analyze. The second simpler strategy would be ED observation without D-dimer. You can see the outcomes here and certain costs along the way. The third group would be simply performing CTPA on all of these patients. And again, they have their outcomes and complications with their associated costs. And this doesn't project, which is great. There's the current U.S. practice is actually a mixed strategy of the other models where patients will either get D-dimer or not get D-dimer and go straight to CTPA. And of the patients who do get D-dimer performed, even those who have a negative D-dimer, some of them still undergo CTPA. So it's the most complicated strategy, what we currently do, and is more of a mixed strategy of the three others that we have. So data was collected from the literature search to be plugged into our decision model. These included incidence of disease and complications, the sensitivity and specificity of the exams that are performed, and we looked at cost data for each of these strategies, and we also looked at the patient utilities, which are measures of patient outcome based on quality of life to plug into and analyze the data. So looking at the results, we have when you plug in all that data, we have our 4 strategies, the cost for each of those strategies per patient, and the quality measures for those. So first I'd like to point out the quality measures show that there's no difference between the patient quality of life outcomes between these 4 different strategies. The differences come in the cost. So when we look at ED observation, it's the most affordable option per patient, followed by the D-dimer plus the CTPA if the D-dimer is positive. Then the current U.S. practice is the next most affordable, and performing CTPA on every patient is the most expensive strategy. As I mentioned, there's no difference in the quality outcomes. So when we analyze this data, we see that ED observation is the dominant strategy over most of the clinically relevant values. However, it's not a feasible option for most emergency departments. So D-dimer followed by CTPA, if positive, is also more affordable without a difference in patient outcome compared to the current U.S. practice. And on our sensitivity analysis, one interesting finding was that if the CTPA specificity is greater than 96%, then the D-dimer followed by CTPA actually becomes the cost-effective and dominant strategy. And so the literature estimates the specificity of CTPA between 89 and 98%. So as long as we think that we're as good as we hope that we are as radiologists and accurate and as specific as we would hope in reading CTPAs for pulmonary embolism, then D-dimer followed by CTPA is the dominant strategy. Here's the results shown in a graphical format. These are incremental cost-effectiveness charts. The chart here is just a diagram to show you how the chart works. There's 4 different quadrants, and the dashed line here is the $75,000 willingness to pay line. In the red, it would mean that we're comparing two strategies, comparing the alternate strategy to the current U.S. practice. If the patients fall in the red, that would mean that it's a worse strategy. If they fall in the green, that would mean that it's a better strategy with decreased cost and increased quality for the outcome. When looking at the ED observation group compared to the current U.S. practice, each of these dots represents a patient run through the model. And you'd see that the patients fall down in the green quadrant below the $75,000 willingness to pay line. That would fall here, showing that the ED observation is the dominant strategy. Also for the D-dimer followed by CTPA, the patients again fall in the green, showing it's a dominant strategy. With CTPA, simply performing CTPA in all patients actually falls above the $75,000 willingness to pay line in the red, and that would be an inferior strategy. We showed that there could be a cost savings estimate for the 600,000 patients. If you perform the ED observation method, you could save over $233 million annually, and the D-dimer followed by CTPA method over $129 million annually. In our conclusions, we saw that ruling out PE in emergency department patients should begin with assessment of risk based on clinical factors, Wells criteria, to ensure that CTPA is not performed in low or very low risk patients. and that potentially avoidable imaging in these patients adds significant cost to the medical system without improving patient outcomes. We propose 2 alternate strategies which are available that can save money without affecting patient outcome. These are ED observation if it's available at your institution, and D-dimer followed by CTPA only if the D-dimer is positive. In the future, we would like to perform a quality improvement project studying the data from our emergency department, and we'd consider a decision-making tool to improve performance, such as Wells criteria and D-dimer as a requirement prior to CTPA for these low-risk patients. And we would also consider modifying our decision model to evaluate other risk factors which were not included in this study, such as contrast reaction, contrast-induced nephropathy, and risk of malignancy from radiation exposure. So we've all heard the phrase, first do no harm, but I prefer from the house of God that the delivery of good medical care is to do as much nothing as possible. I think that we showed that sometimes that's the case. Thank you very much.
Thank you very much. Questions from the audience?
Yeah, very interesting study. Question for you. I don't know if you evaluated whether there were patients that were admitted to the observation unit after having had a negative CT pulmonary angiogram, and if so, what were the costs of the 2 together? In other words, they had a positive D-dimer, a negative CTPA, but were still admitted to the observation unit?
Our method is simply based on the literature. We're looking at the idea of chest pain observation units. For patients, those patients would not have had CTPA performed at all. They would have simply gone to the observation unit for symptomatic management, and so it's based on the rule out chest pain observation units for MIs. So they would actually not have gotten a CTPA.
More questions? We got a question from virtual meeting. What was the pulmonary embolism rate in patients with negative D-dimer?
With negative D-dimer, I believe it was significantly less than 1%. It was like 0.04% is the rate from the literature.
And let me ask you, what's the current policy in your institution? What you guys do right now?
Currently, we basically are doing what the ER is requesting. At night, we do offer VQ scans overnight, but they're not as popular. It seems that CT is the quicker and easier study to obtain, so the ER typically goes to that first. They only go to the VQ scan if patients are allergic or pregnant, and we will call on the tech to perform a VQ scan for those low-risk patients.
Thank you. Dr. Bala, questions? Thank you very much.
Thank you.
Our next speaker is Dr. Yin-Ming Chen from Toronto, and her topic will be variation in utilization and positive rates of CTPA among emergency physicians in academic tertiary emergency department.
Thank you very much. My name is Amy. I'm from the University of Toronto, and my study looks at the ordering rates of CT pulmonary angiogram by the emergency department at my hospital and academic tertiary center. I have no disclosures. So previous studies in this area have shown a very wide variation in the rate of CTPA use and diagnosis of pulmonary embolism among institutions in North America. In particular, more recent papers have shown increased use with concurrent decrease in PE diagnosis rate over the last decade. This occurred despite the establishment of consensus guidelines. Despite the availability of all these institutional level data, there is no previous study looking at the ordering pattern of individual physicians. In the current climate of quality improvement with the goal of more uniform delivery of patient care, we believe this to be an important and interesting metric to examine. Therefore, the purpose of this project is twofold. One, to look at the institutional level of utilization and PE diagnosis rate of CTPA at my hospital, and 2, to break down these rates to the individual physician level and see just how wide the variation is between the ordering pattern of physicians working in one hospital environment. So our study is a cross-sectional retrospective study that looked at 850 consecutive emerged patients with suspected PE who underwent CTPA between 2010 to 2012. The average and individual physician utilization for CTPA and PE diagnosis rates were calculated and correlated with physician characteristics, including years of experience and gender. So first, I'll present our institutional level data. Over the last 3 years, an average of 0.5 CTPA scans were ordered per 100 patient visits. This number has remained relatively stable despite an increase in patient volume at my hospital. If we break this down by age and sex, we see that use is significantly higher in females and older populations. The difference is most striking in the under 30 female group, where females were getting 3 times as many scans as males. A large difference is also seen between the younger and older patients, where patients over 60 are getting scanned more than 2 times as many times as those under 30. So do these utilization rates in females and older populations translate to more PE diagnosis? The answer is no at my hospital. So females and older patients do not have higher positive PE rates based on the CTPA scans. In fact, the PE diagnosis rates were higher in males in the middle of 30 to 60 age group, although not statistically significant. Note also that our institutional average PE rate was 16.7% between 2010 to 2012. Next, we're going to look at physician level data. So the following box plot looks at the variation in the number of scans ordered by individual physicians. 22 full-time emerged physicians were included in this analysis who saw over 2,000 patients in the last 3 years. As you can see, there's significant spread in CTPA use among the physicians, a range between 0.21 scans per 100 patients seen to 0.77 scans per 100 patients seen. An even larger range is seen in the percentage positive PE rate for each physician. Strikingly, there was more than a 6-fold difference among our physicians overall, from 6% to almost 40%. And even if we discard the top and bottom quartiles, the range remains very large, more than a 2-fold difference. When we plot diagnosis rate against utilization in individual physicians, there's no obvious correlation between the two, which means that physicians who are ordering more or less scans are not necessarily catching more PEs. Next, we try to see whether there is any association between physicians' experience, measured as in years in practice since residency, and their utilization and positivity rate. As we can see, there's no significant association with either metric. Finally, we looked at whether there's an association between ordering rates and utilization rates and PE diagnosis rate with physician gender, and again, we didn't see any statistically significant association. So our results of 16.7% overall institutional level positive PE rate is higher than most reported American data, which mostly report values below 10%. The original PILOT-2 study had reported a positive rate of around 18%. Compared to Canadian and European data, our rates are similar to other Canadian institutions and lower than European institutions. Our results of higher utilization rates in females and older populations without significant difference in positive PE diagnosis rates is in agreement with previous published data. Younger females may be imaged more because of an overestimation of risk, and since the mortality rate for PE remains quite high, physicians do not want to risk missing any case. But there's a risk associated with this overutilization, as younger patients, especially females, are most vulnerable in terms of radiation risk. Higher imaging use in older populations in general has been attributed to more difficult and ambiguous clinical exams. Also, we speculate that older patients are more likely to present with symptoms of PE, such as chest pain and shortness of breath. When we looked at individual physician practices, we saw a very wide range of variation. This is a new finding that's consistent with prior studies, which showed that more than 50% of emerged scans did not follow PILOT-2 recommendations. Why is this the case? Possible explanations include physicians' risk tolerance level, lack of knowledge of available guidelines, and differences in prior training and practice experiences. Now, even though the gestalt is to focus on physicians who have a very low positivity rate or who order more, it's equally important to keep in mind that physicians whose positivity rate is high, for example, in our institution, almost 40% may be missing PEs, which may also be dangerous practice. Limitations of our study include the fact that this is a single-center study, so it's difficult to know the external validity of the study. Also, the inter-physician analysis is made based on the assumption that all of our physicians saw similar types of patients during the 3-year period. Also, although we only included full-time physicians who saw over 2,000 patients in 3 years, this may not be sufficient to exclude exaggerated rate calculations due to the overall PE incidence. Finally, calculation rates in the study do not ultimately answer the question of appropriateness of utilization, which is the question that we most want to know. But given what we've found in the study, we believe there's definitely an opportunity for intervention to standardize CTPA utilization among our emerge physicians. And strategies would include continuing education in the indication and cost effectiveness of CTPA, computerized physician order entry with embedded CTPA decision support, something that's been looked at previously, as well as periodic feedback on individual physician CTPA ordering rates and see knowledge of how they're doing relative to the average or relative to their colleagues would change practice patterns. But the baseline data presented here today could be certainly used as a basis to gauge the success of future interventional program. Thank you very much. I'd be happy to take any questions.
Thank you very much. And presentation open for questions. Any questions from the audience?
Thank you for the presentation. I found it most interesting. I was just curious, these physicians who are particularly more sensitive or more specific for detecting these things for PE, are they able, do we have any sense of their false negative rate or their misses? In other words, there are just different senses of thresholds for different people for ordering these scans. I'm wondering if some of these physicians are tending to miss more of them because they tend to be more judicious in ordering them.
Absolutely. I think that's a really good question, and it's something that we are thinking of looking at. The other thing is our data here doesn't really look at patients who are treated for PEs without actually having had a CTPA. So we don't know whether the physician gestalt for whether this patient has had a PE is really represented by their ordering CTPA rate. That's a good question.
Additional questions? Dr. Bala?
I just had one question. Many of our emergency departments have extended physician providers, whether they're nurse practitioners or advanced practice nurses. Do you have any experience with what their rate of detection was like at all?
So at my training institution, currently all the nurse practitioners are actually functioning under a physician. So in this, as same with trainees, so they usually discuss the case, as far as we know, with the ordering physician before making the order. It's certainly possible that some of them are just ordering tests under that physician without their knowledge, but it's difficult to split that data.
And it's interesting. Your data is interesting because one of our insurance providers in St. Louis is toying around with the idea of reimbursement for a study based on a physician's success rate in ordering. And that's interesting because what defines success is still a mystery to me. But,
absolutely,
yeah.
Absolutely. And even comparison to their colleagues, I don't know if that's really the right way to motivate, sticking to guidelines either. It's a...
Stickies.
Yeah, it's a slippery slope for sure.
Do you presently do any intervention with repeated offenders? In my institution, administration, they compile the list and they send emergency physician letters if the detection rate is quite low in comparison to their peers.
So right now, as far as I know, we actually feedback overall physician imaging use for every 3-month period. So we don't really separate CTPA versus other scans, but right now, emerge physicians know how they compare in terms of ordering compared to their colleagues and an overall average rate. And I don't think there is a punishment per se, but I think they just have an idea.
Okay, thank you.
Thank you.
Our last presentation of this session will be by Dr. Charbel Sade from Sydney, Australia, helical thoracic computed tomography angiography, and individualized control protocol, effects on radiation dose and image quality.
Thank you very much. I'd just like to introduce this topic on radiation dose and image quality and looking at contrast. So I'll just discuss really quickly the clinical problems that's currently out there. The current research, we'll look at quantitative analysis and qualitative analysis, and we'll go through the conclusions. Now, when we talk about qualitative analysis, we've tried to exhaustively go through the ROC analysis, kappa analysis, and VGC analysis, which only in the last couple of years has come out as a new research method in image quality. So clinically, we have the acute aortic syndrome, which is classified as aortic dissection, intramural hematoma, and penetrating atherosclerotic plaques. These conditions are indistinguishable if you have a chest X-ray when coming into the emergency department, so CT would be the next step, of course. A lot of problems that still exist out there with rapid advances in technology. People are going from 16 slice to 64 slice, and even 256 or 320. They're still getting artifacts like the superior vena cava, as you see above on the screen. So currently, the most recent research, you see varying levels of contrast volume given to patients. The radiographer will sit on the scanner and he'll give either 100 mils, 120 mils, 160 mils. They're looking at body, weight and size, and they're trying to determine this. But unfortunately, because of timing, we're still getting, sometimes we do get streak artifacts within the superior vena cava. So what we did was we had a 64-slice GE CT scanner. We used the OptiVantage dual barrel injector, and we measured all of our images using the IMPACS AGFA system on a 3.1 megapixel monitor. We looked at two protocols. The first protocol, the first 100 patients, was the standard, you inject your contrast using 100 mils of contrast, and you scan from top to bottom. The second protocol we looked at was a contrast formula where we actually scanned in the opposite direction. And we kept all scanning parameters exactly the same, so your pitch factors, your KVP factors, MA modulation and so forth. But the primary difference between these two is we used two different bolus tracking techniques. The first was a dynamic or triggering bolus technique, and in regimen B we used the test bolus technique. So with these two contrast protocols, we also standardized flow rates between both contrast and saline in both regimens. And we always used right side injection at the cubital fossa in order to look at if there's any variations in time to peak between the cubital fossa and the ascending aorta. So when we looked at regimen A, we looked at standard practice where we looked at the ascending aorta, we injected 120 mils of contrast, and as the contrast opacification rised, we set a pre-threshold at 120 Hounsfield units, and then automatically within 3 seconds the scanner would start to scan from top to bottom. Whereas our second technique, we actually did the test bolus at the level of the diaphragm. So what we did was we sent in 10 mils of contrast and 30 mils of saline, and we measured the time to peak. And that was the pre-threshold that we actually used before we started our scan in the next series. So what we did was, before we talk about this contrast formula, every patient that walks into your examination room or radiology room, you have different heights, weights, cardiovascular dynamics. It depends on their previous diseases. If someone has bradycardia or tachycardia. So all of these factors, it's really hard to predict when a patient is on your scanner table. So what we did was, in order to measure the contrast volume that we used in the second regimen, we looked at the scan time. So we looked at the anatomical coverage. So, tall patients versus small patients. Some will have 2.5 second scan time, others will have 4.5 to 5 second scan time, depending on, of course, your scanner. Then we looked at the time to peak. How fast or how slow did the contrast get there? And then we used the optimal venous washout phase. That is the time it takes on a previous study done by Lee in 2007 and in another paper that we recently published in 2012, where we found out that the time it takes from the cubital fossa to flush the SVC is approximately 12 seconds on average for all patients. So we minus 12 seconds from our formula, and then we multiplied it by our flow rate to give us the contrast volume. So measurements, what we did was, over 7 days we looked at arterial measurements, using the same monitor just in case we get any variations. Then we used the PRISM software for statistical analysis. We used the D. Agostina and Pearson's omnibus test, and of course the Mann-Whitney test as well, which was non-parametric and two-tailed. So when we looked at measuring the opacification levels of the thoracic aorta, we looked at the surgical landing zones, the sinotubular junction, at the aortic sinus, midway through the ascending aorta, and so forth. What we found in regimen A, we found that the highest contrast opacification we got was 348 Hounsfield units, and the lowest we had was 324. Now, we looked at regimen B, we found that the highest we had was 368 Hounsfield units, and the lowest was 357. So looking at how fast or how slow contrast gets there will predetermine the level of opacification within the vessel. When we looked at venous opacification at the superior vena cava at the same level of the mid-ascending aorta, we found in regimen 8 it was 1,500 Hounsfield units on average, and 796 at the SVC, because you could have the esophagus vein going in there, so we'll definitely dilute it. Whereas in regimen B, we reduced that down to 159 and 123 Hounsfield units, and we had statistical significance. Then we took it to the next level. We looked at, okay, we've got a really bright artery, and we've got a really opacified artery, and then we have a non-opacified superior vena cava. Then we started to look at the difference of ratios between those two, and we found that it was 2.9 times higher in regimen B in terms of arterial opacification versus the venous opacification. So between the two regimens, there was a 12% increase in arterial opacification. There was a 92% reduction in venous opacification in the superior vena cava and the brachiocephalic vein. And the arterial-venous contrast ratio showed at the two different levels 90% and 86%. So we then proceeded to do a ROC analysis between 6 cardiovascular radiologists, and we also introduced a vascular surgeon. There is a dilemma, or not a dilemma, a debate between a vascular surgeon and a radiologist. Who knows more? Because a vascular surgeon says, I know my patients because I'm a vascular surgeon. I do interventional. I do CT scans. I can look at it better than a radiologist. So we tried to dismiss this fact and theory. So what we did was we looked at 40 cases, regimen A and regimen B. In the first 10 cases of each regimen, there were normal studies which were approved by radiological reports and also ongoing post-CT scanning. And then the other 10 were varying levels of pathology from mild, moderate to severe pathology. And then we did the ROC analysis using the DBM method and kappa analysis as well as VGC. So just to let you know that level 7 is the vascular surgeon. Okay? If you have a look at regimen A, the mean ROC analysis we got as 0.87. If you look at regimen B, we got to 1. Okay? So all of them were getting the right pathology correct between the radiologist and the vascular surgeon. Then we looked at the visual grading characteristic. This type of test on image quality looks at the quality of the wall of the ascending aorta. So for a radiologist to have a look at the wall of the aorta to correctly diagnose an aortic dissection or a PAU or a hematoma or intramural hematoma, we looked at the quality of the wall. And what we found was with higher levels of opacification and increased reduction levels of venous opacification, we found that the radiologist was more confident in giving their diagnosis. So we looked at kappa analysis. It went from moderate to good at 0.6. And so with the contrast volume that we used in regimen A, it was 120 mils. We actually reduced contrast volume by about 57% using this formula. And the limitation in this study, unfortunately, we did not go into looking at the rates of contrast-induced nephrotoxicity, but this would definitely be the next step. And till date, there's all these hydration therapy methods, looking at creatinine, eGFR, and so forth. But ideally, in the current situation of what we know right now, is try and reduce your contrast volume as much as possible. Then, of course, we looked at radiation dose. We looked at scan time between each regimen because we wanted to look at the level of radiation dose between using 120 mils and 68 mils. They were both equal and there was no statistical significance. Scan range was also equal in both groups, and also the mean length product, or the mean dose length product, demonstrated significant reduction in regimen B versus A. So we actually found, that body height, weight, age, and sex was equally distributed, and there was no significance between the two groups. we've actually found that reducing contrast volume further reduces radiation dose to the patient during that examination. So just a couple of examples of what we talk about. You can have a look here on the first image on your left. It doesn't really well project up there because that looks like that's enhanced. On my screen here, that's not enhanced to SVC. And you can see a small fenestration of a slow-flowing dissection. If you look in the coronal plane, you see that the level of the right atrium is actually completely washed out and you have good opacification within the ascending aorta. Now, there are differences when you're looking at CTA of the thoracic aorta, whether you do it helical or gated. Okay, so, I mean, that's another study we're looking at as well. This is a really interesting patient as well who had aortic coarctation. When we scanned from bottom to top, we actually found that this little small area where the contrast was just trickling through, we gave it more time for the contrast to get in there to reach peak opacification from the ascending down to the descending aorta. So just in conclusion, you know, so far we've done about 3,000 patients till date on this technique. We've increased our vascular opacification by 12%. We've reduced venous opacification by 92% in the brachiocephalic and superior vena cava. There was increased arterial venous contrast ratio comparison at up to 90% increase. Contrast volume reduction at 57%. Radiation dose reduction on average was 34%. And there was an increase in pathology detection between the two groups. And what makes it a lot easier as well is this. Between the radiologist and the vascular surgeon, they're both now giving informed decisions whether during the day or within the evening. Thank you very much.